Welcome everyone. Welcome to the IFSO webinar, and I'd like to bid everyone a good morning or a good afternoon or good evening to wherever the IFSO members are. I welcome you to tonight's or this evening's webinar, which is to look at the best of Obesity Week, which was held in Vegas, November 3rd to the 7th. This webinar is to illustrate the best studies that were presented for those who could not attend or those who would like to come and just listen to the highlights presented this evening. I'd like to welcome my two moderators, Dr. Matthew Hutter, who is the president of ASMBS. I'd like to welcome Ahmed Bashir, the moderator, who is the chair of the Communications Committee. Today we have 4 presentations: Dr. Eric DeMaria, Dr. John Scott, Dr. Richard Peterson, and Dr. Kothari. We're going to start off with Dr. Maria's presentation, and I'll hand this webinar to the two moderators, Dr. Hatta and Dr. Bashir. Once again, welcome everyone.
Thanks, Lillian, very much, and participate in this Best of Obesity Week. We're calling it the ASM conference going forward. We look forward to having everybody there. Actually, I think the best part of Obesity Week in the ASMBS annual conference is actually being there. So we look forward to having people there at Atlanta next year because it's really the friendships, it's the people, it's the conversations in the hallway that make a difference. We're trying to transport that a little bit here today, tonight, this morning, wherever you are. Morning for us, Central European time, 1:30, and Lillian, a little bit different timing, but we're glad that everybody's going to participate today. We hope to have an active discussion, give the 4 talks, but have breaks in between, and look forward to hearing everybody's voices. So kicking it off will be Dr. DeMaria. He's the president of the ASMBS, and he'll be presenting the initial study, which was our top paper from the presentation, which was on the Individualized Diabetes Complications Risk Score, Future Risk of Diabetes and Organ Complications with and without Metabolic Surgery. The author, Ali Aminian, was the presenter at the meeting, and this is from the Cleveland Clinic, and includes past presidents Stacey Brethauer and Philip Schauer as part of the authors. So Dr. DeMaria, kicking us off.
Great, thank you, Matt. If you guys can go ahead and Manuela, invite me. Oh, here we go. I think I got it. Let's see if you can see my screen, everyone. Okay. Do we have the screen up, the slides, folks?
Yes, you do, Dr. DeMaria.
Thank you. So it's my honor to share work that was not done by me, obviously, but I would like to represent this work, which was one of our top papers. Matt already mentioned Ali Aminian, who was the lead author in terms of the presentation at the meeting in Vegas. This is an interesting work from the Cleveland Clinic. They have been working on kind of a 3-stage project. In stage 1, and this has already been published, they work to associate metabolic surgery with end-organ complications of type 2 diabetes and obesity. And then in the current study that we're going to look at, identification of predictors of major adverse cardiac events, or MACE, and construction of a risk calculator. And then in a future study, they hope to do a randomized clinical trial to show the usefulness of such a risk calculator in their study. Now, this is the reference to their previous baseline work, looking at the population that they studied and published in JAMA regarding these major adverse cardiovascular events. And this was a retrospective study. Inclusion criteria: adult age 18 to 80, body mass index over 30, and hemoglobin A1C greater than 6.5%. They compared 2,287 surgical patients to a propensity matched group at a 1-to-5 ratio with 11,435 control patients who received usual care, and these are patients all from the Cleveland Clinic institution. Here's a look at the various metabolic surgery procedures that were performed. You'll see a predominance of gastric bypass and sleeve gastrectomy and a minority of gastric banding, and also just a tiny group of duodenal switch. So this is a caveat to remember as we look at the results, that this really doesn't reflect the impact of duodenal switch on diabetes complications, this calculator. So here again, baseline characteristics, the variables that were examined: age, gender, body mass index, race, hypertension, coronary disease, insulin use, hemoglobin A1C, LDL level, and GFR or kidney function assessment. And here's some of their population comparisons. The metabolic surgery group had lower all-cause mortality, a lower rate of heart failure, a lower rate of coronary artery disease, a lower rate of nephropathy. So the basis for their performance of this exercise to develop a calculator was the low utilization rate of surgery eligible patients. And they were looking for a way to help patients and their physicians understand that the patients could receive significant benefits by calculating their own risk and looking at how that risk might change with surgical treatments. So again, they used the cohorts from the stage 1 study that was published and developed this calculator. And here's some of the background. They did choose a 10-year time point to look at the outcomes. So that's in the development of this individualized diabetes complication risk score, or IDC risk score. That's the time point that we're looking at. So I want to share with you just briefly what has transpired with this work. First, this is an app, Bariatric Calc, that they developed at the Cleveland Clinic that has the risk calculator on it. And then because of the importance of this work, the organization ASMBS was very excited to get involved and try to disseminate this risk calculator, which is a very unique development in our field. So you'll see the URL here, the escapediabetes.org website that ASMBS has developed to try to go direct to patients to educate them about metabolic and bariatric surgery. And just wanted to share with you a little bit from this escapediabetes.org website, which was a takeoff from the paper, and we worked with Dr. Aminian to develop it. So this is a patient-facing website. It's very simplistic. You see the nomenclature Escape Diabetes, which was carefully chosen, although somewhat controversial in some people's mind, that we would suggest you can escape from diabetes. And we've tried to point out that we're specifically talking about type 2 diabetes. So here's the beginning of the website. It's an ASMBS website. And the provocative and controversial question for patients: why have they chosen to remain people with diabetes or diabetic patients, and what are you waiting for? It has a find a provider function to it so that patients can seek out care. And here's an example of the output of the risk calculator based on entering the characteristics of the patient, which includes some laboratory values. We did struggle a little bit with how to put the lab values in, because sometimes patients don't know what their lab values are, and there is a default for this that we'll just put in normal values. So you can see the output of the calculator starts with mortality, 10-year risk, and it compares your risk without surgery to your risk with metabolic surgery, and then the absolute change in 10-year risk. And then we can see in this example here, there's a 42% reduction in 10-year risk compared to patients who've not had surgery, metabolic surgery outcomes. So you can see it shows heart failure, diabetic kidney disease, and the major adverse cardiovascular event of stroke. So we felt this was very important information to try to get into the public realm. And this paper and this work by Dr. Aminian really enabled that to happen. So this is a first effort to identify predictors and develop a risk calculator. And these IDC scores, these risk scores, we hope can provide a personalized evidence-based information for patients so that they can predict what their lives might look like if they choose the usual care route or if they choose metabolic surgery to treat their type 2 diabetes and other comorbidities. So again, really important contribution, I think, from the Cleveland Clinic and Dr. Aminian's great research group. So thank you very much. Nice opportunity to present and showcase their work.
Matt, you're muted.
There you go.
Is that better? Eric, thank you very much for presenting that, and more importantly for Ali Aminian and the folks at Cleveland Clinic who put this together. I think this is a great representative of how you can use science and bring it actually back to the patient. So leverage a website, leverage a risk calculator, and use science actually to impact the patient care. So great work by Ali Aminian, by the Cleveland Clinic group, and I think a great effort throughout the ASMBS in order to try to echo this and get this important message out. I do want to point out that questions are online, so please type in your questions, and we'll be able to then address them in real time. So this is your opportunity. As the presentations are going, type in your questions, and as we have this during these discussions, please type in the questions so we can start with that. Any other comments or questions from the panel?
I would actually want to ask, thank you, Dr. Di Maria, for sharing this valuable instruments, and I think it's an instrument that we can use worldwide. The issue with this calculator is I'm just forecasting that us surgeons will be using it more than the medical side. Is there an intention to try to implement it from the medical side? Is ASMBS going to talk to the medical community about this calculator? How are we going to involve the medical side with that?
Yeah, it's a great and important question, and I think the calculator was initially developed to really be focused on medical providers using it as opposed to patients. And we did make some modifications in terms of trying to make it more user-friendly for patients, like having default settings if they don't know certain values. I do think it's very important to get it in the hands of the providers. I do agree that surgeons are probably more likely to use it than medical providers. And we have heard already a little bit of pushback from some of the medical providers on this Escape Diabetes website, where they think we may be being overly aggressive in trying to appeal to the diabetic patient community. I think my perspective on that is it comes from frustration, knowing that we have such excellent treatment modality it's invasive with surgery, but it's very effective. And knowing that we still sit at the 1% or less level of utilization for this therapy while we sit back and watch this epidemic disease grow and grow. So I think, yes, we are being aggressive with it, and maybe more so than people would traditionally be with these concepts. But I personally think it's time that we got more aggressive.
Hey, Eric, This is Rich, and John can help, and Eric, you can probably remember, I believe also another way this is going to get out is I think they had asked for an exemption in their manuscript. They'll be publishing it in a medical journal, if I'm not mistaken. Is that correct, Eric? You remember?
I think they did ask for an exemption, yeah, so it may or may not appear in SWORD depending on whether they gain traction with a wide circulation journal.
Yeah.
And then Eric, go ahead.
One of the things in working closely with IFSO and people around the world is that we want to borrow blamelessly or steal shamelessly. That's stolen from quality improvement. But really, we want people to use this to get the word out. If it's just sitting there and that's not very helpful. So any opportunity you have to get this word out would be wonderful. Putting it on your websites, the risk calculator, all the more people who have their hands on it, the better. Shano.
Yeah, I'd be curious what the panelists' thoughts are in terms of utilizing this in the workflow in the clinic. Is this something you could have your patients fill out in the waiting room? It's a little, absolute risk reduction versus relative risk reduction. These are challenging concepts for laypersons, but we as the providers can help interpret that for the patients. Is that part of the workflow that people anticipate utilizing this in your day-to-day practice as well?
I would like to see it become part of the electronic medical record, that the EMR pulls the data to populate the fields and provides it, because I think it's going to be important that the information of this calculator and future calculators be provided to the medical folks who are caring for these patients, that they can see right in front of their eyes what the risk is to this individual patient.
Well, that's great. Eric, thank you very much for presenting it. Thank you, Ali Aminian and the whole Cleveland Clinic group for putting this forward. And we'll move on to the next talk. The next talk will be presented by Dr. John Scott. It's about, is it worth it? Determining the health benefits of sleeve gastrectomy in patients with a body mass index less than 35. So this presentation presented by Oliver Varbin on behalf of the University of Michigan group. Other notable authors include Jonathan Finks and Amir Ghaffari. Includes data from the Michigan Bariatric Surgery Collaborative, which is a collaborative from their state. And again, one of the top papers that's presented. It'll be presented by Dr. John Scott, who is the chair of the program committee for this upcoming year. So he'll be highlighting what's going to happen at Atlanta, and excited for having everybody to come to Atlanta as well. John Scott is at the University of South Carolina School of Medicine in Greenville. Dr. Scott.
Thanks, Matt. So I think this is a really important paper and was very well presented at Obesity Week, and I love the opportunity to share this with the international community. As far as background, here in America, we've been somewhat handcuffed by the 1991 NIH Consensus Conference, which set the original standard for who was a candidate for bariatric surgery at a BMI of 40 or a BMI greater than 35 with the presence of medical comorbidity. And we know that metabolic disease is something that is more prevalent beyond the borders of someone with a BMI higher than 35. In their background slide, they presented one of these international papers that demonstrated, especially in Asian Americans, patients with BMIs as low as 25 can still have the presence of metabolic disease. So their objective for this particular study was to analyze patients that had lower BMIs at the time of their operation. Did they experience the same health benefits as individuals with higher BMIs in relation to the sleeve gastrectomy? Their data source was the Michigan Bariatric Surgery Collaborative, which is a group of programs in the state of Michigan. There are 43 programs, 81 individual surgeons. They've been able to collect data on over 85,000 cases. In this particular study, they analyzed patients between the time frame of 2006 to 2018, and specifically looking at preoperative characteristics of those patients, 30-day risk-adjusted complications, and most importantly, one-year patient-reported outcomes. As far as their division of their groups, individuals that had a BMI less than 35 on the day of surgery were compared to those individuals that had BMIs greater than 35. Now, obviously, because of the handcuffs that have been placed on our bariatric surgeons by insurance companies and other policymakers, you can see there's definitely a skew toward patients that have higher BMIs than 35. So in terms of the groups, around 1,000 patients with BMIs less than 35 and around 45,000 patients with BMIs greater than 35. You can see these individual groups are relatively identical in terms of age, comorbidity status, BMI, and their weight of surgery. There are some differences here. In general, the lower BMI patients were somewhat older, obviously had lower BMIs, lower weights. They were a little bit more skewed toward the female population, and the patients were more skewed toward being non-white. In terms of their preoperative comorbidities, the less than 35 BMI group had some slightly higher percentages of preoperative comorbidities. You can see that these patients tended to have more type 2 diabetes, higher rates of hyperlipidemia, sleep apnea, gastroesophageal reflux disease. And this is because I believe the surgeons were selecting out patients that already had the presence of metabolic disease, even if they had lower BMIs. In terms of the outcomes, this is some striking data. Their weight loss, the lower BMI group had a greater a lower amount of overall weight loss, but they had a greater percentage of being able to achieve a normal BMI. So you can see here in this column, the patients that had lower BMIs to start had the better opportunity to get down to a lower normal BMI, which would be less than 25%. I mean, a BMI of 25. In addition, you can see there's some striking data as far as being able to come off CPAP machines. However, the resolution of hypertension, hyperlipidemia, diabetes was somewhat similar to the over 35 BMI group. And more importantly, patients with lower BMIs, BMIs less than 35, were much more satisfied overall with their operation than patients that had higher BMIs. You can see there were some similarities from the two groups as far as depression and psychological well-being. But once again, here in the lower BMI category, these patients had a higher body image score in the postoperative phase. Complication rates for two groups were somewhat identical. There were no statistical differences between complication rates in lower BMI individuals versus those that had BMIs greater than 35. So in conclusion, these patients that are in the lower BMI category were older and had higher rates of comorbidity going into the operation, were more female and non-white. The comorbidity resolution rates were high, greater than 50%. But most importantly, patients with lower BMIs were more likely to achieve a normal BMI and had a higher quality of life, including a more improved body image. And so their conclusion, which I wholeheartedly agree, and so does our society, is that the current guidelines for bariatric surgery should be reconsidered to focus on the presence of metabolic disease and should not be married to a specific BMI. The reason why I think this paper is important is because I think we need to completely do away with the concept of the 1991 National Institutes of Health Consensus Guidelines for BMI rates. I think that in our industry, especially here in the United States, that we've kind of celebrated and educated our colleagues on these guidelines. They're in slideshows, they're in webinars, they're on our materials that we hand out to patients. And we need to get away from that. We need to, as a society, stick to our own recommendations and some of our own ASMBS consensus guidelines that we've set forth within the past several years, and try to focus on the the patient and their comorbidity status, their overall health, and determine ourselves their suitability for metabolic surgery.
John Scott, thank you very much for presenting that paper there on behalf of Oliver Varbin and the whole Michigan group. I agree. I echo what you said about the low BMI, and I do think that this is a great opportunity, to be honest, for the international folks to really help us, whether it's in technology, patient populations. We have such restraints. You use the word handcuffs, and I think that's really appropriate. Handcuffs about who we can operate on, and other people's experience, either from East Asia or from the international community, could really help us to provide the care needed to the patients that need it the most. So we look forward to that. I do want to give a shout out to all the attendees. Please ask questions. Click on just ask a question. We'll be happy to answer that. And we look forward to that as well. So other comments from the panel?
From an Asian point of view, it's been shown that a lower BMI results in a higher risk of metabolic disease. And as you know, in the Asia Pacific region, the cutoff for bariatric surgery is 2 points lower than what's accepted in the NIH and the other regions of the world. So I commend this paper because it reinforces what we believe in the Asia Pacific region, that the BMI should be certainly lower and based on metabolic conditions.
One other comment. I think there are plenty of papers actually from the International Society coming up with BMI lower than 35. And one of them is for one of the procedures that is not approved yet in the ASMBS, one anastomosis gastric bypass, as well as sleeve gastrectomy and other procedures. The one thing that the medical community keeps on pointing out as far as bariatric surgery in BMI less than 35, and Dr. John Dixon in the recent IFSO actually pointed out in the IBC symposium, is there is no survival, long-term survival outcomes of bariatric surgery in lower BMIs. And the medical side had actually disturbing data, which is higher mortality in patients who lose weight in BMI less than 35, especially in patients who have diabetes. I welcome any comments from the Dr. Scott and the panelists.
I definitely agree that a lot of our low BMI information has started from the international community, and certainly the ASMBS published several consensus statements regarding some of the review of a lot of the international literature, especially involving sleeves. And we certainly commend the international community for kind of leading the way, and hopefully we can also kind of in this country limit the scope of what those older guidelines have led for our community.
Great point. I think this is very, very helpful, and I hope we can move the tide with regards to who we can offer these operations to in the United States, using this kind of literature, bringing it to our policymakers, giving to our insurers. Hopefully, can get these people the care that they can benefit from. I also want to point out, I thought it was very interesting, the quality of life aspect of it. And if the expectation is that you get to a normal weight, a BMI of 25, if that's the expectation of our patients, then a lot of our patients are going to be disappointed. And so here we have patients who get to the BMI of 25, that may be in their mind. Maybe that's not what we say, but perhaps we need to say it better. Manage those expectations in order to have a better patient experience. And that's maybe why in the higher BMI groups, really to a BMI of 25, if that's in their mind, then that's a hard thing to counteract. So we need to do that better. A small point that I just thought looking at the data there.
I would, if I could just jump in, I think the other comment was that there's some medical data that suggests that there may be higher mortality. And I would say that that would surprise me. I've not seen that, and be the first study that I'm aware of that ever shows a higher long-term mortality with metabolic surgery. Love to see what that reference is.
Those data, Dr. Di Maria, not with bariatric surgery, actually, it's with medical weight loss.
Okay.
Yeah, not with bariatric surgery.
We can't help them.
Yeah.
Thanks for clarifying. That makes a big difference.
But you know, the outside lacks the survival outcomes as far as BMI less than 35, and that's one of the criticisms that Dr. John Dixon had in IFSO.
One of the other critiques, because that's been shown before, I think, is that there's no clear reason that the patients are losing weight, which includes that they're sick, you know, or they have cancer or other problems. So it's hard to sort out that group.
Good. A good discussion. Let's move on to paper 3. John Scott, again, thank you very much for presenting that. The next presentation will be by Dr. Rich Peterson. The study is on gastroesophageal reflux disease in patients with severe obesity and type 2 diabetes 1 year after sleeve gastrectomy or Roux-en-Y gastric bypass. This is a randomized trial. The first author, Jolanta Lorentzen, is from Tonsberg, Norway. This is one of the top 10 papers like I talked about before. In fact, 2 of the top 10 papers were from international groups, and this being one of them from Tonsberg, Norway. Today will be Dr. Rich Peterson. Rich was the chair of the program committee, so he helped run Obesity Week this year. A lot of hard work went into that. He was also elected by our membership to be on the executive council. So the executive council of the ASMBS total, who are council people at large, who are voted in by their members. So it's quite an honor and a big response. And Rich is up for that. John Scott also being on the council as well. So Rich.
All right. Well, thank you so much. I appreciate it. And I appreciate the opportunity to present this work from Sweden. And this study, I think, is very interesting. It was definitely in one of our top papers. And the big thing is it helps us address a controversy that we continue to have with respect to type 2 or with respect to reflux after the sleeve gastrectomy as well as gastric bypass. And the very nice thing about this study is it's an extension of a study they already had going on in Tonsberg. They call this the Osberg study because of the obesity surgery in Tonsberg. And so this aspect is focusing specifically on reflux. It's a triple-blinded randomized study, which is pretty impressive to me as well. So I'm happy and honored to be able to present their work. So just a little brief about where this is located in Norway. The background essentially is that obesity and type 2 diabetes, there's a high prevalence of gastroesophageal reflux disease in these groups. Obesity and reflux, as we know, is associated with risk factors: increased intragastric pressure, increased gastroesophageal pressure gradient, increased chemoreceptor sensitivity to acid, decreased lower esophageal sphincter resting pressure, a presence of a hiatal hernia or not, and then, of course, esophageal body motility. Symptoms, of course, there are those patients who have heartburn or acid regurgitation. There are also the silent refluxers. Evidence of esophagitis as noted on endoscopy, and then complications of that can be strictures, Barrett's esophagus, and ultimately esophageal adenocarcinoma. They look specifically at both operations, the gastric bypass and sleeve gastrectomy, that are performed most commonly there, and these are the 2 that were randomized. Interestingly, this is a paper that came out of obesity surgery in 2018 by Angrasani, looking at bariatric surgery worldwide. And as you can see, over the last decade, the volume has doubled in terms of that numbers of surgeries being performed. The majority of that is secondary to the sleeve gastrectomy. So if you look at the total line on the top, which is the black line, you can see in that time period, 685,000 bariatric surgeries were performed. And of that, the sleeve gastrectomy went from about 18,000 in 2008 to almost 340,000 in 2016. You can see the red line, which is the gastric bypass, is pretty stable across all the time. The purple, the adjustable gastric band, as you are not surprised, has gone from its numbers down to lower. And then the one anastomosis gastric bypass, which is the orange line, is you can see beginning to build a little bit of traction worldwide as well. The BPD DS kind of stays flat and low at the moment. This again, as I mentioned, is a extension of their study that they were doing originally. They originally published in the British Medical Journal their methodology for this triple-blinded study, and now looking at in this study, the Osberg reflux study is looking at gastroesophageal reflux disease at 1 year after surgery. Their inclusion criteria were if the patients had type 2 diabetes, and they used the hemoglobin A1C of greater than 6.5, over 18, and morbid obesity, meaning current BMI greater than 33, or previously verified BMI greater than 35. The major exclusion criteria were previous major abdominal surgeries, severe reflux disease. They excluded people with LA grade class C and D or Barrett's esophagus if they had any history of cancer or severe medical conditions, and obviously, like anything, drug or alcohol addiction or pregnancy. Their study timeline approved the protocol in 2012, had their first patient included within 2013, and had 1 year follow-ups completed in 2019. They have plans to publish their data for 5-year follow-up. So they wanted to compare the 1 year effects of sleeve gastrectomy and Roux-en-Y gastric bypass on post-op reflux symptoms, esophagitis, and pathological acid reflux. Their hypothesis was that 1 year after surgery, patients undergoing sleeve gastrectomy, compared with those undergoing bypass, would have more reflux symptoms, higher prevalence of erosive esophagitis, higher prevalence of pathologic reflux, and higher prevalence of de novo esophagitis. Their statistical analysis comprised this way. So in their methods, they looked at the GSRS, which essentially looks at question of heartburn and acid regurgitation. They also, as mentioned, looked at classification of esophagitis based on the LA grade classifications. And as I mentioned, they excluded C and D. They did 24-hour pH measurements. As you know, score greater than 14.72 is pathologic acid reflux as a Demeester score. And so the results in their study, they initially looked at 319 patients. There were 101 ineligible, 93 of them declined participation. They enrolled 125, and ultimately 109 were randomized, 55 to the sleeve gastrectomy group and 54 to the gastric bypass. Their follow-up is great. They only lost 1 to follow-up in each group. And so if you look at the overall, there really weren't many differences between the characteristics of the two groups, so they were quite similar in both. And so looking at their data, the proportion of patients with GSRS symptom scores greater than 20, on the left-hand side, you see this is at baseline, and the sleeve and bypass are very similar. The sleeve is in the lighter gray. And at 1 year, you see an improvement in both. The bypass is a bit better than in the sleeve. The prevalence of erosive esophagitis, both were very similar at baseline in the two groups, and at a year out, there was improvement in both, but that was not statistically significant. And then esophagitis greater than LA grade B, that went down. There was a smaller group, as noted, and at 1 year after, you can see the two groups are quite similar, so no statistical significance between the two groups at 1 year. Those with pathologic reflux, again, very similar at baseline, but a statistically significant difference for those patients in the sleeve gastrectomy group at 1 year after being worse in that group. And then and the de novo esophagitis, again, 1 year after gastric bypass, much improved, whereas in the sleeve it was statistically worse. Those requiring anti-reflux medications in the bypass group, interestingly enough, had a higher proportion, but 1 year later, significantly less. Well, not quite statistically significant, but close. So their conclusions, and I think it was interesting as they proposed their own hypothesis, that at 1 year, did they have more GERD symptoms? They actually did not. At 1 year, did they have higher prevalence of erosive esophagitis? They did not. They had a higher prevalence of pathologic reflux, though, and they had a higher prevalence of de novo esophagitis. So I think it's very interesting with this group. Go to reflux being so much more improved in the gastric bypass, which many of us go to, but the reality is it may not be as of a cure, as much of a cure as we want to say it is in many cases, as this study is kind of showing. So I'm happy to welcome any questions at this time.
And I'll remind the attendees to go ahead and ask questions online. We look forward to that. Any comments or questions from the panel?
Yeah, this is Sean Couture. We need more studies like this. I would have loved to have seen this if it had included manometry pre and post as well, to see what component these two most common procedures impact that aspect of esophageal clearance. I think it's always important to know that the mechanism of most of our anti-reflux procedures are focused on the sphincter, which is weakened, damaged, and incompetent, and shorter in patients typically with pathologic reflux. And when we do gastric bypass, we're really just eliminating the acid pocket or the acid load or the acid aliquot we're not really focusing on the sphincter in that situation. It's almost like a permanent chemical, PPI therapy, if you will. So it's a different strategy. I'd be curious also that some of the patients on higher PPIs afterwards in the bypass group might be for marginal ulcer or marginal ulcer prophylaxis. I'd be curious if that's the reason for that component as well. I don't know if this was composite data versus did they break it down into, you can really be in 3 categories. You can have acid reflux, pathologic, and then it improves after your intervention, either sleeve or bypass. It can stay the same or it can worsen. Did they break those groups out, meaning the patients that showed improvement, were they the actual ones who had it pre-op, or was that a mixture of new onset patients afterwards? Because that, I think, is an important distinction for both sleeve and bypass.
Sean, I agree with you. I think that's great. I love the idea that this is a triple blind study, number one. Number two, I do think that the manometry would have added some extra data. I think they were so incredibly thorough. But to your point, I do not believe that the data that they showed, it was all de novo. It was post-surgical stuff. So I do believe that they've separated it out as such. It wasn't delineated exactly, but since they're listing it as de novo, I believe that's exactly correct. But I do think, to your point, it would be nice to ensure that we're not including the same refluxers pre and post, looking specifically at new onset. So I believe that was the thrust of it. That's based on just the slide deck here. I want to see the full manuscript, but yeah, that's what I can tell.
Well, kudos to the authors. I think, it shows how much you can do with 110 patients. We have those in each one of our clinics, and randomizing it, getting a good scientific study, getting hard endpoints, using patient-reported functional outcomes as well, I think is really important, and it's provided a lot. This makes a difference for me when I'm talking to a patient about what operation they should have. This discussion about reflux, so having hard data, I think, is critical. All right, any other comments before we go ahead and move to the presentation?
One more question to Rich, if you allow me. Thank you. This is a very fascinating study, an amazing study actually, and look forward to the 5-year data. Specifically looking at the reflux post-sleeve long-term, since one of the papers that Dr. Hempens suggested is there's a dual pattern of improvement, and then if you follow patients longer, there's a tendency of reflux to increase after the 1 year post sleeve. How do you see this paper influencing the other papers looking at Barrett's and the fear of the neoplasia post sleeve?
Yeah, no, well, that's a great question. I actually think that this, so to your point, I think exactly right. Hippen showed that, the reflux that sort of comes back in at that later time period. So I definitely would be interested to see what the 5-year data shows here. But for right now, I mean, they're showing an improvement. I think that this downplays to a degree the amount of reflux, the de novo reflux in the sleeve gastrectomy group post surgery. So I think, because we see that, to your whole point, we see numbers going up to, 30%, and others down in other studies at 10%. I mean, this group here doesn't show that. It shows on the lower side, which I think is a good thing. They're clearly completely blinded to it during this part, so there's definitely no bias in terms of interpretation. So my hope is that the 5-year data from this study will guide us a little bit better. But I agree with you. That's a good point.
Thank you.
All right. Well, thank you very much. We do have one question, but it's only partially typed in, unfortunately. It says, I mean during an operation. So that's not a full question, but we look forward to having a question. People are able to put those in. Let's move on to the next. The next is the long-term outcomes of single anastomosis duodenal ileal bypass with sleeve gastrectomy. It was presented as one of the top 10 in Neil Cotton from Salt Lake City. Presenting today would be Dr. Shanal Katari. Shanal Katari is Vice Chair of Medical Staff Affairs at University of South Carolina School of Medicine in Greenville, and he is the President-elect of the ASMBS. So Shanal.
Thanks. Can you guys see the slides?
Yes.
All right. So again, I have the privilege of presenting this on behalf of Dr. Cotton, who has been a champion and a pioneer in this particular procedure. And this is his long-term data that he presented, again, as one of the top papers. As we all know, duodenal switch has been one of our endorsed procedures by ASMBS for years. It is a very powerful metabolic intervention, but it comes at a price as well in terms of macro and micronutrient deficiencies. The question is SADE a major modification of this by eliminating anastomosis and the Roux effect, or was it a completely independent new procedure in and of its own? And so Dr. Cotton believes that it is a simpler version of the DS, and this is his center's experience with this from a long-term standpoint, because we know there is really no long-term data in the literature. And that was the goal of this particular paper. You can see that this was 724 patients that were part of this. You can see the assessment that was done in terms of pre-op acquisition of data. The follow-up was pretty standard that many of us use in our Barrett clinics, regardless of procedure performed. In terms of the technique, again, it starts with identification of ileocecal valve, measuring 300 centimeters proximal to that and marking that and tacking that up approximately while the sleeve is then created. The duodenal dissection was then performed, followed by transection, and then the end-to-side duodenal ileostomy, followed by an endoscopy with a bubble test. You can see that the average age of 49 and BMI 49, probably pretty typical to many of our practices that we see for those of us who don't offer this procedure currently. And also in terms of obesity-related comorbid conditions, you can see the prevalence of those here. They defined high risk as a BMI over 55 or age over 65 as a separate cohort. The operative time, as you can imagine, this is a pioneer in this field, so probably includes not only his outcomes of his learning curve, but also now that he is They've mastered it, so it's a pretty quick operation, as you can see there. A pretty remarkable length of stay as well. So out of these total of 724 patients, obviously this is rolling data over the years to come, and so the farther you get out, the less patients you have for follow-up. But the ASMBS recognizes 5-year follow-up as long-term follow-up. And so you can see the cohort there of 166 patients and 82 respectively at 6 years out. The short-term complication rate was 7.1%, very small number that presented to the ER or was readmitted. Again, most commonly because of nausea or vomiting, perhaps not unlike our sleeve experience. And then this is a list of the short-term complications, again, totaling about 7%. And you can see the variety of short-term complications. I think unique to this is only one leak at the duodenal ileostomy, and probably maybe unique to the proximity of this anastomosis to the liver is the hepatic abscess, which is pretty rare, as we know, and if anything has been described with the duodenal liner. The rest of them are as listed there. The long-term complication rate was 9.1%, and interestingly, this was most commonly the stricture. And again, I assume, I don't know if this is at the duodenal ileostomy versus at the incisura, but otherwise chronic longer-term complications are as listed here on this slide. In terms of the weight loss outcomes, focusing on those who are in the 5 to 6 year range out, you can scroll to the bottom and see the percent excess weight loss at 5 and 6 years of 77 and 85% respectively. Pretty impressive data. And for those who live more in the percent total weight loss, again, 35 and 37% of that available cohort that far out. Again, an impressive durability of this particular operation. The trade-off, of course, the more powerful our metabolic intervention is also the risk of micronutrient and macronutrient deficiencies. This slide is a little busy, but notable. You can see those in summary that are improved. Of course, was the diabetes, the triglyceridemia. Interestingly, also the vitamin D improved and ferritin improved in this cohort that both had a disproportionately very high abnormality of both of those preoperatively, but as to be potentially expected, similar to the DS, the calcium PTH, hypoalbuminemia, as well as total protein, vitamin E, and zinc levels did worsen in this cohort. In terms of comorbid conditions, resolution improvement and unchanged and worsened, you can see respectively listed on this slide. Obviously, it's a very powerful anti-diabetic intervention as well, as listed here at 72% remission. And failure rates with SATI, again, you can argue that less than 50% excess weight loss may be a flawed metric, but nevertheless, it's one that's in the literature. And you can see here by year 6, there's a very small percentage of patients who would meet that definition if one were to use it for failure. This is another way of just seeing that metric played out over the years in this graph, pretty steady. And then comparing it to perhaps the literature on sleeve versus bypass in terms of range of quote unquote failures. If you're going to continue to use that metric, you can see that it has the lowest failure rate compared to bypass, and then of course sleeve. So in conclusion, the author felt that the longer term results of SATI offers good results, both in terms of obesity remission and its obesity related conditions, but that further long-term studies would be required to confirm this particular author's institutional results. Thanks.
Thank you, Shonal, for presenting that paper on behalf of Daniel Cottam. The ASMBS has endorsed ADS procedure as an endorsed procedure, and we look forward to the safe introduction of this in the United States. It's unclear. Currently, the numbers, as shown previously, are quite small in the U.S., and whether this will catch on, become more of a provided more frequently, is still yet to be determined. I don't see any questions online. Any comments or questions from the panel?
I'd like to ask a question. Thank you, Dr. Kalari. It's an amazing work, 700 plus patients of SARIs. Now, the interesting part, these are patients that were done as a one-stage procedure, not two-stage sleeve and then the SARIs part, right?
I believe these were all primary procedures, correct?
Yeah. My thoughts are, if we have a sleeve patient who is presenting with weight regain after sleeve gastrectomy, and you look at the long term, there is a 13 to 16% risk, as you mentioned, that the patient would not lose more than 50% excess. Still, 85% do well. Thoughts are, if that patient falls under a body mass index of more than 50, would you use SARIs versus DS as a thought process? And what would you do in that instance?
Yeah, I think it's an excellent question. I think, how do we, we haven't gotten to the point yet where we can metabolically predict responders, partial responders, and non-responders to the various procedures that we currently offer. But I think SADI will be have an opportunity to distinguish itself, certainly in the U.S. and in the world, as a second intervention following partial responder after sleeve gastrectomy. So, we have certain battles, of course, like many do, in terms of coverage, insurance, but and access to care from these standpoints and from secondary interventions, because we have in the U.S. we have many health plans that have one bariatric intervention per lifetime, which doesn't really make sense as a chronic disease. We don't see that with any other intervention for a disease process. But I think that's where it's going to have some. I think it's going to have some potential.
Excellent and good comments. Any other comments from the panel here?
I think as more and more of this procedure is being done, I think with the results will show that this procedure will prove itself. Our last position statement at IFSO, which was issued 2 years ago, we said that this was a safe and effective procedure, but more studies will need to be done. And this coming year, 2020, is when the next position statement from IFSO will be released on the SADI.
Thank you very much, Lillian. And thank you, everybody, today for presenting this work from the Best of Obesity Week. I think it's a great conference. We encourage everybody to attend next year in Atlanta. This is only a little tidbit of what's presented. There's a lot more in person, a lot more videos. In fact, videos this year were from IFSO members, international videos, so highly regarded, and we want people to submit their abstracts, their videos, and more importantly, come to the meeting, because I think it's great. We can learn a lot from you. We have handcuffs on the techniques and technologies that we can currently do, and the more we can learn from you all, the better. So thank you very much for being part of this. Lillian, can you conclude the meeting for us?
Certainly. Well, I'd like to thank all the presenters. It certainly shows just a glimpse of the quality of the papers that were presented as ASMBS. I myself have enjoyed tonight's presentation. I'd like to thank all the presenters. I also would like to tell all IFSO members that tonight's webinar, as well as all our previous webinars, are actually available to members on our website, and they can take their time at leisure to view these webinars and to learn from it as well. So once again, thank you everyone for tuning in, and thank you to the presenters. Thank you, Matthew, and thank you, Ahmed, for also moderating this session.
And thank you to the IFSO staff, specifically Manuela, for pulling this all together. Bye-bye.
Thank you.
Thank you.
All right, goodbye everyone, and we'll see you next time.